Hi, welcome to Fastech. My name is Stacy Lyons and I'm a physical therapist. I've been treating patients with foot and ankle and lower extremity dysfunctions for nearly 20 years. For most of my career, I've found that orthotic therapy can be a very nice complement to traditional physical therapy modalities. In today's video, I'd like to spend some time discussing traditional and maybe not so traditional considerations for orthotic application within your patient population. To start, I wanted to just give a little bit of background from an anatomy perspective on some of the things that we're looking for in the foot when we consider or evaluate for orthotic therapy. So, looking at a healthy foot, we'll be spending a lot of time talking about the medial longitudinal arch. And this arch is, its basic function in the foot is to go through a healthy and accurately or appropriately timed pronation period during weight bearing and specifically during gait. When the medial longitudinal arch pronates, that happens at the subtalar joint, it allows for the force that is applied through the ground reaction to be applied over a period of time. When we have an arch that is not functioning in a normal way, there is a variety of things that can happen that can lead to dysfunction. So if we spend a few minutes talking about a patient that has a hypermobile or overpronating arch. And this can happen for a variety of reasons. It can be a hypermobile joint. It can be that there is a dysfunction of the subtalar joint that creates a moment of pronation that either happens too long or too long or too quickly in the gait cycle. When that happens, what we see is that the medial longitudinal arch falls and that there is an excessive amount of strain or lengthening of the plantar fascia, which connects from the calcaneal tuberosity to the forefoot. When that happens, the strain on the plantar fascia through repetitive loading can create plantar fasciitis, which is one of the most common ailments that we see and often provide orthotic therapy for within the practice. However, in addition to that overpronation creating an overload on the plantar fascia, it also creates a moment of excessive internal rotation through the lower limb. So when that happens and the limb rotates internally, there is a significant amount of increased strain on the joints above or more proximal to the foot. So when we think about that, some of the conditions that are classically seen in a hypermobile or overpronating foot would be things like the bunions or hallux abductus valgus, HAV for short, and that's because that internal rotation creates a moment of increased lateral strain or lateral force on the first metatarsal joint. Over time, this repetitive force creates a valgus load, and you can see the deformity happen at the first met head. Additionally, some of the things that you may see because of the excessive movement into pronation is a loading or a strain on the back of the calcaneus at the insertion of the Achilles tendon. So Achilles tendonitis can be a very common condition that's actually coming from excessive pronation of the foot and can really be supported through a formed arch or the appropriate amount of posting or accommodation to create a more stable position for the foot to function in. Some additional things of consideration higher up the chain would be that internal rotation of the limb will create an excessive valgus strain at the knee. And so we can have chondromalacia patellofemoral syndrome, or patellotendinitis, all conditions that we see really commonly in a less stable or overpronating foot. In orthotic therapy, a set of conditions that is not looked as often to address in orthotic therapy would be the high rigid arch. So when we think about orthotic therapy, we often think that our goal is to just support the arch. And from a practical perspective, there is a lot of value in orthotic therapy being used to correct for some physical bony dysfunctions of the foot that create abnormal movement as you go through a traditional gait pattern. So what I'd like to talk about a little bit today is how to provide orthotic therapy for the high rigid arch or the over-supinated arch, what we might say, that doesn't go through the healthy pronation that we talked about earlier, that creates that shock absorption, unlocks the foot, allows it to work as a ground, both a support but also as a stabilizer. So when we talk about pronation, to reiterate, the purpose of pronation is to absorb shock by allowing the force to be absorbed through a short moment of time. When you don't have pronation, that ground reaction force is immediately absorbed up the kinetic chain. And so if you can imagine that force being absorbed up the chain, there are specific dysfunctions that you can see as a result of that. One would be ankle sprains. So because you are not absorbing the shock through the foot and allowing that foot to react to the ground or unlock to meet the ground, your tendency is to move towards the outside or lateral aspect of your foot, and ankle sprains can be a result of that dysfunction. Another is the stress fractures. So as you're unable to absorb that moment of force and ground reaction force in the foot, that consistent and repetitive load on the lower limb can create stress fractures. We often see these in high performance young athletes. And then finally, plantar fasciitis, the one we spoke about initially in the hypermobile foot, can also have a presence in the rigid supinated foot. And that's because there is a shortness, as you see in this model demonstration, between the calcaneus and the metatarsal head, and that plantar fascia is shortened. And over time, that creates an excessive pull on the calcaneus, and we see this in the classic presentation of plantar fasciitis. One final condition I wanted to bring to light as an easy opportunity to utilize orthotic therapy is a condition in which you lose a third arch in the foot, which is called the transverse metatarsal arch. So this is the arch that is on the metatarsal heads, and a reduction in the size of that arch can create decreased space between the metatarsal heads. That can cause increased pressure on the metatarsal heads themselves, or it can create a pinch or a pressure in the nerves that run between the metatarsal heads. This classic condition is called Morton's neuroma. So if you're doing an accommodating orthotic, one that you would be either doing within your clinic or sending to the lab for posting and accommodations, one opportunity is to use a metatarsal pad. This is placed underneath the transverse metatarsal arch and creates an increased height of that arch to unload the metatarsal heads, take the pressure off of the nerves, and can often be a very quick fix for Morton's neuroma. What we've done today is talk about some classic clinical presentations. I think it's also important to note that orthotic therapy can really be used as a preventative measure as well. So looking at patients and trying to avoid the repetitive use or to decrease the impact and shock absorption at the loads on the foot and the lower chain can be a really good prophylactic to reduce the impact and the potential for injury down the road. That can be through our mold and go options that we have available, as well as some prefab off-the-shelf retail options as well. For more on these different options within your practice, or to see some of the special materials that we have available in the Fastech line, please see the additional videos we have available. Thank you.